Hello everyone, and welcome to another stream of advanced pharmacology. Today we're talking about chapter 37, our calcium channel blockers. Calcium channel blockers, or CCBs, are drugs that prevent calcium ions from entering cells. These agents have their greatest effects on the heart and blood vessel. CCBs are used widely to treat hypertension, angina pectoris, and cardiac dysrhythmias. Since 1995, there has been controversy about the safety of CCBs, especially in patients with hypertension and diabetes. So, calcium channels, the physiology, functions, and the consequences of blockade. Calcium channels are gated pores in the cytoplasmic membrane that regulate the entry of calcium ions into cells. Calcium entry plays a critical role in the function of vascular smooth muscle and the heart. So, speaking directly on the vascular smooth muscle. In vascular smooth muscle, or VCM, the calcium channel regulates contraction. When an action potential travels down the surface of the smooth muscle cell, calcium channels open and calcium ions flow inward, thereby initiating the contractile process. If calcium channels are blocked, however, the contraction will be prevented and vasodilation will result. At a therapeutic dose, calcium channel blockers act selectively on the peripheral arterioles and arteries of the heart. CCBs have no significant effect on veins. The heart. In the heart, calcium channels help regulate the myocardium, the sinoatrial or SA node, and the atrioventricular node or AV node. Calcium channels at all three sites are coupled to beta 1 adrenergic receptors. So in the myocardium, in the cardiac muscle itself, calcium entry has a positive inotropic effect. That is, calcium increases the force of contraction. If calcium channels in the atrial and ventricular muscles are blocked, the contractile force begins to diminish. So, the sinoatrial node, pacemaker activity of the SA node, is regulated by the calcium influx. When calcium channels are opened, spontaneous discharge of the SA node increases. Conversely, when calcium channels close, pacemaker activity declines. Therefore, the effect of calcium channel blockade is to reduce the heart rate. Bringing us to the atrioventricular node. Impulses that originate in the SA node must pass through the AV node on their way to the ventricle. Because of this arrangement, regulation of the AV conduction plays a role in the coordination contraction of the ventricles with contraction of the atria. The excitability of the AV node cells is regulated by calcium entry, however. When calcium channels are open, calcium entry increases, and the cells of the AV node discharge more readily. Again, conversely, when those calcium channels are closed, discharge of the AV node cells is suppressed. Therefore, the effect of a calcium channel blockade is to decrease velocity of the conduction through the AV node. So, coupling of calcium channels to beta adrenergic receptors. In the heart, calcium channels are coupled to beta 1 adrenergic receptors. As a result, when the cardiac beta 1 receptors are activated, calcium influx is enhanced. Again, conversely, when the beta 1 receptors are blocked, the calcium influx is suppressed. Because of this relationship, your calcium channel blockers and beta blockers have identical effects on the heart. That is, they both reduce the force of contraction, they slow heart rate, and suppress conduction through the AV node. So here you're taking a look at the coupling of the cardiac calcium channel with a beta 1 adrenergic receptor. It's a wonderful spot to hit pause, especially if you're unfamiliar with the physiology aspect of how these medications work. So, speaking on calcium channel blockers, the classification and the site of action. So, classification. The calcium channel blockers are used in the United States belong to three chemical families. The largest family is the dihydropyridines, for which nifedipine is the prototype. This family name is encountered frequently and is hence is worth remembering. The other two families consist of orphans. Verapamil is the only phenylalkylamine and diltiazem is the only benzodiazepine. The drug names are important and the family names not so much. We definitely should at this point know verapamil and diltiazem, as well as nifedipine. So they're all pretty important in their own significant ways. So here in table 37.1, again, is an excellent spot to hit pause if you're unfamiliar with some of these calcium channel blockers. Especially since they have different classifications, sites of action, and their indications. So, site of action. At therapeutic doses, the dihydropyridines act primarily on the arterioles. In contrast, verapamil and diltiazem act on arterioles and the heart. Again, if you look at that table, it'll specify that. However, although dihydropyridines don't affect the heart at therapeutic doses, toxic doses can produce dangerous cardiac suppression, similar to that of verapamil and diltiazem. The differences in selecting among the calcium channel blockers are based on the structural differences among the drug themselves and structural differences among the calcium channels. So, verapamil and diltiazem, agents that act on the vascular smooth muscle and the heart. So, we'll start with verapamil. Verapamil blocks calcium channels in blood vessels and in the heart. Major indications are for angina, essential hypertension, and cardiac dysrhythmias. Verapamil was the first calcium channel blocker available and will serve as the prototype for the group. Its hemodynamic effects. The overall hemodynamic response to verapamil is the net result of direct effects of the heart and blood vessels and its reflex responses. So its direct effects. By blocking calcium channels in the heart and blood vessels, verapamil has 5 direct effects. The blockade at peripheral arterioles, which causes the dilation and thereby reduces the arterial pressure. Then, the blockade at arteries and arterioles of the heart, which increases your coronary perfusion. The blockade at the SA node, which reduces the heart rate. The blockade of the AV node, which decreases the AV node conduction. And finally, the blockade of the myocardium, which decreases the force of contraction. Over the direct effects on the heart, the reduced AV conduction is the most important. So we spoke about now direct effects. There also are indirect effects, or reflexes. Verapamil-induced lowering of blood pressure activates the baroreceptor reflex, causing increased firing of sympathetic nerves to the heart. Your norepinephrine released from the nerves act to increase the heart rate, your AV conduction, and the force of contraction. However, because these same three parameters are suppressed by the direct actions of verapamil, the direct and indirect effects tend to neutralize each other out. So there is a net effect. Because the direct effects of verapamil on the heart are counterbalanced by the indirect effects, the drug has little or no net effect on cardiac performance. For most patients, your heart rate, your AV conduction, and the contractility are not noticeably altered. Consequentially, the overall cardiovascular effect of verapamil is simply vasodilation, accompanied by the reduced arterial pressure and increased coronary perfusion. So, how does that work in the terms of pharmacokinetics? Verapamil may be administered orally or intravenously. The drug is well absorbed after oral administration but undergoes extensive metabolism on the first pass through the liver. So, consequentially, only about 20% of an oral dose actually reaches the systemic circulation. Its effects take about 30 minutes after dosing, and your peak kind of triggers at around 5 hours. The elimination is primarily by the hepatic metabolism. Because the drug is eliminated by the liver, doses must be reduced substantially in patients who have hepatic impairments. Its therapeutic use, therefore. Again, the first one was angina. Verapamil is used widely to treat angina. The drug is approved for vasospastic angina and angina of effort. Benefits in both disorders derive from vasodilation. The role of verapamil in angina is going to get discussed further in chapter 43. Essential hypertension. Verapamil is the second-line agent for chronic hypertension, used after a thiazide diuretic. The drug lowers blood pressure by dilating arterioles. The role of verapamil and other calcium channel blockers in hypertension will be discussed further in chapter 39. Cardiac dysrhythmias. Verapamil administered intravenously is used to slow the ventricular rate in patients with atrial flutter, atrial fibrillation, and paroxysmal supraventricular tachycardia. The benefits derive from suppressing impulse conduction through the AV node, thereby preventing the atria from driving the ventricles at an excessive rate. Your antidysrhythmic application is going to get discussed in further detail in chapter 41. There are adverse effects. The common effects of verapamil is generally well tolerated. However, constipation occurs frequently and is the most common complaint. This problem, which can be especially severe in the older adult population, can be minimized by increasing dietary fibers and fluid. Constipation results from the blockade of calcium channels in that smooth muscle of the intestine. Other common side effects include dizziness, facial flushing, headaches, and edema of the ankles and feet, secondary to that vasodilation. Cardiac effects. Blockade of calcium channel in the heart can compromise cardiac function. In the SA node, the calcium channel blockade can cause bradycardia. In the AV node, blockade can cause partial or complete AV block. And in the myocardium, blockade can decrease contractility. When the heart is healthy, these effects really have any kind of clinical significance. However, in patients with certain cardiac diseases, verapamil can seriously exacerbate dysfunction. Accordingly, the drug must be used with special caution in patients with cardiac failure and must not be used at all in patients with sick sinus syndrome or second degree or third degree AV blocks. Other effects. In the older patient population, calcium channel blockers have been associated with chronic eczematous eruptions, typically starting 3 to 6 months after treatment onset. If the reaction is mild, switching to a different calcium channel blocker may help. However, if the condition is considered severe, the use of verapamil and any other calcium channel blocker should be stopped. Gingival hyperplasia, or the overgrowth of gum tissue, has also been reported. So drug and food interactions. The big one that we should always speak about is digoxin. Like verapamil, digoxin suppresses the impulse conduction through that AV node. Accordingly, when these drugs are used concurrently, the risk for an AV block is increased. Patients receiving the combination should be monitored closely. Verapamil increases plasma levels of digoxin by about 60%, thereby increasing the risk for digoxin toxicity. If signs of toxicity appear, digoxin dosage should be reduced. Now, speaking on the beta-adrenergic blocking agents, so beta blockers. Beta blockers and verapamil have the same effect on the heart. Again, they decrease the heart rate. your AV conduction and contractility. Therefore, when a beta blocker and verapamil is used together, there's a risk for excessive cardiosuppression. To minimize this risk, beta blockers and intravenous IV verapamil should be administered several hours apart. Grapefruit juice. Grapefruit juice can inhibit the intestinal and hepatic metabolism of a lot of different types of drugs, and thus raise their levels. In a case report on verapamil toxicity, the consumption of grapefruit juice and verapamil led to a verapamil blood level of 2,772, which was, I guess, 360 milligrams over 24 hours, which is about 8 to 24 times higher than would be achieved without grapefruit juice, meaning it truly is exacerbating the medication. So it, again, should not be given together. Grapefruit juice should be at this point common sense contraindicated in just about every medication. Your toxicity. Clinical manifestations. Your overdose can produce severe hypotension, any cardiotoxicity, because bradycardia, AV blocks, and ventricular tachydysrhythmias can still occur. So your treatment. General measures. Verapamil can be removed from the gastrointestinal tract with a gastric lavage, followed by activated charcoal. Intravenous calcium gluconate can also counteract both the vasodilation and the negative inotropic effects, but it will not reverse an AV block. Your hypotension. Hypotension can be treated with IV norepinephrine, which promotes the vasoconstriction by activating alpha-1 receptors on blood vessels and increases cardiac output by activating beta-1 receptors in the heart. Placing the patient in a modified Trendelenburg position and administering IV fluids may also help. Bradycardia and AV block. Both can be treated with a medication called atropine, which is an anticholinergic drug that blocks parasympathetic influences on the heart. If pharmacologic measures are inadequate, electronic pacing may be required. The use of glucagon in animal models have improved heart rate through increasing amounts of intracellular cyclic adenosine monophosphate. It has been used successfully in treating humans in cases who have a calcium channel blocker toxicity. And finally, ventricular tachydysrhythmias. The preferred treatment is direct current discontinuation of or DC cardioversion. Antidysrhythmic drugs such as procainamide and lidocaine may also be tried. So it's preparation, dosage, and administration. When discussed orally, verapamil is available in immediate release tablets at 40, 80, and 120 milligrams. As sustained release tablets, they can run at 120, 180, and 240 milligrams. There are also suspended release capsules in 120, 180, 240, and 360 milligrams, and in timed release formulation at 100, 200, and 300 milligrams. The sustained and timed release formulations are approved only for hypertension. You want to instruct your patient to swallow these medications intact without crushing or chewing. A fixed dose combination is also available with an ACE inhibitor. The initial dose for angina pectoris is 80 to 120 milligrams 3 times daily. The usual initial dose for essential hypertension is 80 milligrams 3 times a day. Again, keep in mind, because your patients who have hepatic issues, especially that older patient population, dosages should be reduced, and dosages for dysrhythmias are going to be specifically discussed in chapter 41. Your IV verapamil is only used for dysrhythmias because IV verapamil can cause severe cardiovascular effects. Blood pressure and electrocardiograms should be monitored, and equipment for resuscitation should be available immediately. IV dosages for dysrhythmias are again discussed in Chapter 41 in further detail. Which brings us to the next one, your diltiazem or cardizem. Similar to verapamil, diltiazem/cardizem blocks calcium channels in the heart and blood vessels. As a result, the actions and applications of verapamil and diltiazem are very similar. Diltiazem has the same effects on cardiovascular function. Both drugs lower blood pressure through arterial dilation, and because their direct suppressant actions are balanced by reflex cardiac stimulation, both have little net effect on the heart. Similar to verapamil, diltiazem is used for angina, essential hypertension, and cardiac dysrhythmias. Again, AFib, aflutter, and paroxysmal supraventricular tachycardia. Its pharmacokinetics. Oral diltiazem is well absorbed and then extensively metabolized on the first pass through the liver. As a result, bioavailability is only about 50%. Its effects begin rapidly and peak within half an hour. The drug undergoes nearly complete metabolism before elimination in the urine and feces. Its adverse effects are similar as verapamil, except that diltiazem causes less constipation. The most common effects are dizziness, flushing, headache, and edema of the ankles and feet, again because of that vasodilation. Like verapamil, diltiazem can exacerbate cardiac dysfunction in patients with bradycardia, sick sinus syndrome, heart failure, and a second or third degree heart block. Like other calcium channel blockers, diltiazem may cause chronic eczematous rashes in the older adult population. So there is a patient-centered care across the lifespan on calcium channel blockers. An excellent spot to hit pause and review. Drugs and food interactions. Again, like verapamil, diltiazem can exacerbate the digoxin-induced suppression of an AV conduction and can intensify the cardiosuppressant effects of a beta blocker. Patients receiving diltiazem concurrently with digoxin or a beta blocker should be monitored closely for cardiac status. And again, grapefruit juice is pretty much contraindicated as it significantly increases the levels of diltiazem. Its preparations, there are a bunch of different varieties, but the most common is the IR tablet at 30, 60, 90, and 120 milligrams as cardizem, and the extended release versions of 120, 180, 240, 300, 360, and 420 milligram as cardizem LA. There are, again, a variety of different versions of this in terms of extended release and different oral and IV solutions. So I will let you pause here so you can review them all. Um, there's a bunch. It's going to be kind of difficult to just read them all out. Pause, read it through. Do you need to know them specifically for each one? I'll leave that up to you. I'll personally will be moving on. Dihydropyridines, agents that act mainly on vascular smooth muscle. All of these drugs discussed in this section belong to the dihydropyridine family. At therapeutic doses, these drugs produce significant blockade of calcium channels in blood vessels and minimal blockade of calcium channels in the heart. The dihydropyridines are similar to verapamil in some respects, but quite different in others. So again, the big one that we will talk about will be nifedipine. Nifedipine, also known as Procardia or Procardia XL, was the first dihydropyridine available and will serve again as the prototype for this group. Like verapamil, nifedipine blocks calcium channels in the vascular smooth muscle and thereby promotes vasodilation. However, in contrast to verapamil, nifedipine produces very little blockade of calcium channels in the heart. As a result, nifedipine cannot be used to treat any kind of cardiac dysrhythmias, does not cause cardiac suppression, and is less likely than verapamil to exacerbate any kind of pre-existing cardiac disorders. Nifedipine also differs from verapamil in that nifedipine is more likely to cause a reflex tachycardia. Contrast between nifedipine and verapamil are shown here in the following table. So here you'll see the comparisons. It's a good spot to pause so you can kind of take a look at it all, um, just to kind of familiarize yourself with them. Cardizem, I'm sorry, not cardizem. Nifedipine does have hemodynamic effects. Its direct effects of nifedipine on the cardiovascular system are limited to the blockade of a calcium channel in vascular smooth muscle. Blockade of that calcium channel in peripheral arterioles causes vasodilation and thereby lowers your atrial pressure. Calcium channel blockers in arteries and arterioles of the heart increases coronary perfusion. Because nifedipine does not block cardiac calcium channels at usual therapeutic doses, the drug has no direct suppressant effects on the automaticity, so your AV conduction or contractile force. It also has indirect effects. By lowering blood pressure, nifedipine activates the baroreceptor reflex, thereby causing sympathetic stimulation of the heart. Because nifedipine lacks direct cardiosuppressant actions, cardiac stimulation is unopposed, and therefore heart rate and contractile force increases. It's important to note that the reflex effect occurs primarily with the immediate release formulation of nifedipine, and not with the SR formulation. This is because the baroreceptor reflex is turned on only by the rapid fall in blood pressure. A gradual decline will not activate this reflex. With the IR formulation, blood levels of nifedipine rise quickly, and hence blood pressure drops quickly, and the reflex is turned on. Conversely, with the SR formulation, blood levels of nifedipine rise slowly, so blood pressure falls slowly, and the reflex is blunted. It does have net effect. The overall hemodynamic response to nifedipine is simply the sum of its direct effect and indirect effect. Accordingly, nifedipine lowers blood pressure, increases the heart rate, and increases the contractile force. So please note, however, that the reflex increases in heart rate and contractile force are transient and occur primarily with the IR formulation. Pharmacokinetics. Nifedipine is well absorbed after an oral administration, but undergoes extensive first-pass metabolism. As a result, only about 50% of the oral dose reaches the systemic circulation. With the IR formulation, effects begin rapidly and peak in 30 minutes. With the SR formulation, effects begin within 20 minutes and peak in 6 hours. Nifedipine is fully metabolized before its excretion in the urine. So, its therapeutic use. In angina, nifedipine is indicated for the vasospastic angina and angina of effort. The drug is usually combined with a beta blocker to prevent reflex stimulation of the heart, which could intensify anginal pain. Long-term use reduces the rates of overt heart failure, coronary angiography, and coronary bypass surgery, but not any kind of rate of stroke, myocardial infarction, or death. The role of nifedipine in angina will be discussed in closer detail in Chapter 43. In hypertension, nifedipine is used widely to treat essential hypertension. Only the SR formulation should be used. In the past, nifedipine was used for hypertensive emergencies, but it has largely been replaced with drugs that are considered safer. The use of a calcium channel blocker is essential hypertension is discussed further in Chapter 39. So adverse effects. Some adverse effects are like those of verapamil. Others are quite different. Like verapamil, nifedipine can cause flushing, dizziness, headaches, peripheral edema, and gingival hyperplasia. It may pose a risk for chronic eczematous rashes in the older patient population. In contrast to verapamil, nifedipine causes very little constipation. Also, because nifedipine causes minimal blockade of calcium channels in the heart, the drug does not likely exacerbate any kind of AV block, heart failure, bradycardia, or sick sinus syndrome. Accordingly, nifedipine is preferred to verapamil for patients who have these issues. In response that others or a response that occurs when nifedipine that does not occur with verapamil is reflex tachycardia. This response is problematic in that it increases cardiac oxygen demand and can thereby increase pain in patients who have angina. To prevent reflex tachycardia, nifedipine should be combined with a beta blocker, such as metoprolol. Your immediate release nifedipine, your IR nifedipine, is associated with increased mortality in a patient who have myocardial infarction and unstable angina. Other IR calcium channel blockers have been associated with an increased risk for myocardial infarction in patients with hypertension. However, in both cases, a causal relationship has not been established. Nonetheless, the National Heart, Lung, and Blood Institute has recommended that the immediate release nifedipine, especially in high doses, be used with caution, if at all. It is important to note that these adverse effects have not been associated with sustained release nifedipine or with any other long-acting calcium channel blocker. Your drug interactions with, for instance, your beta adrenergic blockers. Your beta blockers are combined with nifedipine, again to prevent reflex tachycardia. It's important to note that whereas beta blockers can decrease the adverse cardiac effects of nifedipine, they can intensify the adverse effects of verapamil and diltiazem. Toxicity. When taken in excessive dosage, nifedipine loses selectivity. Therefore, a toxic dose affects the heart in addition to blood vessels. So, consequently, the manifestations and treatment of nifedipine overdose are the same as described for verapamil. Again, your dosages for and preparations for nifedipine have a variety of dosage. It's available in IR capsules in 10 and 20 milligrams, and it's called Procardia, and in SR tablets 30, 60, and 90, which is known as Procardia XL. Again, instruct patients to swallow your tablets whole, no crushing, no chewing, especially if they are taking SR tablets. For treatment of angina, the usual dosage is 10 milligrams 3 times a day, and there's a maintenance dose of 10 to 20 milligrams 3 times a day. The maximal recommended dosage is 180 milligrams per day. For essential hypertension, only the SR tablet is approved, and again, the initial dosage is 30 milligrams once a day. There are other dihydropyridines. So in addition to nifedipine, there are 7 other medications that are available. All are similar to nifedipine, and like nifedipine, these drugs produce a greater blockade of calcium channels in the vascular smooth muscle than in the heart. So, nicardipine. At therapeutic doses, nicardipine, or Cardine SR, produces selective blockade of calcium channels in blood vessels and has a minimal effect on the heart. The drug has 2 indications: essential hypertension and effort-induced angina. The most common adverse effects are flushing, headache, asthenia or weakness, dizziness, palpitations, and edema in the ankles and feet. As with other calcium channel blockers, eczematous rashes may develop in the older patient population. Gingival hyperplasia has also been reported. Like nifedipine, nicardipine can be combined with a beta blocker to promote a therapeutic effect that suppresses reflex tachycardia. Its dosages are a variety. I'll let you pause and read those. And again, it's important to note that there are different dosages for different treatments. Which brings us to amlodipine. Amlodipine, also known as Norvasc, produces a selective blockade of calcium channels in blood vessels, having minimal direct effect on the heart. Approved indications are essential hypertension and again angina. Amlodipine is administered orally and absorbed slowly. Peak levels develop in 6 to 12 hours, and the drug has a half-life of 30 to 60 hours. Therefore, it's effective with a once-a-day dosing. Principal adverse effects are peripheral and facial edema. Flushing, dizziness, and headache may also occur, as again in the older patient population, that eczematous rash. In contrast to other dihydropyridines, amlodipine causes very little reflex tachycardia. Again, your dosaging is very different. Hit pause to review them. There's also a wide series of combo drugs. Again, hit pause so you can see all the different types. There are a bunch. Isradipine, also known as Dinacirc, produces relatively selective blockade of calcium channels in blood vessels. In the US, the drug is approved only for the use of hypertension. Isradipine is rapidly absorbed after oral administration but undergoes extensive first-pass metabolism. The parent drug and metabolites are excreted in the urine, and the most common side effects are facial flushing, headache, dizziness, and ankle edema. Eczematous rashes again develop in the older patient population, and in contrast to nifedipine, isradipine causes minimal reflex tachycardia. The drug is available in 2.5 and 5 milligrams, and the usual beginning dose as an antihypertensive medication is 2.5 to 5 milligrams twice a day. Felodipine, also known as Renadil. Felodipine produces a selective blockade of calcium channel in blood vessels. Again, in the US, the drug is approved only for the use of hypertension. Felodipine is well absorbed after an oral administration and undergoes extensive first-pass metabolism. As a result, its bioavailability is low, only about 20%. Your plasma levels peak in 2.5 to 5 hours and then decay with a half-life of 24 hours. Because of its prolonged half-life, it's effective for once-a-day dosing. Your characteristic adverse effects are reflex tachycardia, peripheral edema, headache, facial flushing, and dizziness. Again, eczematous rashes also occur in the older patient population, and gingival hyperplasia has been reported. The medication is also available in extended release tablets, and there is a combo drug with an ACE inhibitor called enalapril. Nimodipine or Nimotop produces selective blockade of calcium channels in cerebral blood vessels. The only approved application is the prophylaxis of neurologic injury after the rupture of an intracranial aneurysm. Benefits derive from preventing cerebral arterial spasms that follows a subarachnoid hemorrhage and can result in ischemic neurologic injury. Dosing is 60 milligrams every 4 hours and should begin within 96 hours of a subarachnoid hemorrhage, and continue the use of this medication for 21 days. Your nimodipine or Nimotop is available in 30 milligram liquid-filled capsules for oral administration and as a 60 milligram 20 ml oral solution. Nimodipine must never be given intravenously owing to the risk for potentially fatal cardiovascular events. Leading us to nisolodipine. Nisolodipine produces selective blockade of calcium channels in blood vessels. The drug has minimal direct effect on the heart. The only approved indication is hypertension. Nisolodipine is well absorbed after oral administration, but the first pass effect limits bioavailability to 5%. Plasma levels peak 6 hours after administration, and again, the most common side effects are dizziness, headache, and peripheral edema. Reflex tachycardia may occur, as with other calcium channel blockers. The eczematous rash develops in the older patient. The medication is also available in extended-release tablets, and the dosage for hypertension is usually 20 to 60 milligrams a day. And that concludes this chapter for today. I thank you for listening, and I'll see you at the next chapter. Till then, take care.